Well, good evening, everyone, and thank you for joining the first of our OSSA Asia Pacific OA and Injury Solutions webinars for 2018. My name is Chris Wallace, and I'm the Clinical Education and Product Marketing Manager. So tonight, I'm going to briefly run through our OA and Injury webinars for those who are not familiar with them or have not joined any of our webinars in the past. I'm then going to give a brief overview of our Spinal Interest Group meeting that was recently run in Melbourne before we play a recording of one of our guest presenters from the Spinal Interest Group, Greg Etherington. So for many of you, you may have joined some of our webinars either on our OA and Injury Solutions or prosthetics side of the business in the past. But for those of you who are, for this being your first webinar, we try and run on our OA and Injury Solutions side a quarterly webinar. Many of you would have registered through links through pre-registration because you're part of our mailing list, but you also have the opportunity to register directly via our OSSA website. For future reference, if you're not on our mailing list and would like to be notified of upcoming webinar events, please just contact me or your local OSSA representative and we can add you to that mailing list. On our website, you also have access to a catalogue of our past webinars, both for prosthetics and for our OA and Injury Solutions. So to access that, if you go to our OSSA website, if you click on About OSSA in the top banner, you can then click on OSSA Academy in the left-hand navigation pane, and to get to the OA and Injury Solutions webinars, there's a tab there. Immediately above it is the prosthetic webinars. So here you'll have access to the webinars that took place last year. So there's a recording which you can download and view at your convenience. So as I mentioned, OSSA Australia recently held the 4th Spinal Interest Group meeting at the beginning of March. The Spinal Interest Group is a multidisciplinary group that was created to foster education, discussion, research and collaboration in spinal orthotics care. The Spinal Interest Group meetings are open to practitioners involved in spinal orthotic care or with a particular interest in spinal orthotic care. And they have typically had a high focus on halo management. This year, the event in Melbourne attracted over 60 delegates from across Australia and New Zealand, and the 2-day event featured a program of lectures, clinical presentations, and small group practical sessions, with a couple of keynote presentations, one being on the first day from Mr. Greg Etherington, a consultant spine surgeon at the Alfred Hospital, whose presentation you'll hear immediately after this. But we were also fortunate to be joined by a mix of other presenters. So Leah McLaughlin kindly agreed to present on the management of paediatric spinal injuries. Leah is an orthotist from the Royal Children's Hospital here in Melbourne. And then on the first day after lunch, the group broke into small groups and ran through complex spinal case studies. This was a really interesting session that elicited a lot of engagement and good conversation, and I think it was a really good learning experience and knowledge sharing experience for people of varying degrees of experience. The second day, we were very fortunate to be joined by Dr. Helen Ackland, who's a Senior Clinical Research Fellow at the National Trauma Research Institute at the Alfred. So she presented on cervical spine clearance protocols, and it was certainly an eye-opening presentation that she gave with some frightening statistics on some of the causes of major trauma and traumatic brain injury. So we're hopefully going to be able to put that into a webinar format that we can present to you later in the year. There was a halo fitting and adjustment practical session for those less experienced in the application of halos, so that gave them some hands-on experience of how to actually apply a halo. And for those that were more experienced with halo management, they broke into a separate group and again rolled through some rotating case studies of complex halo cases and some of the complications that you may encounter throughout the wearing regime. And through this, they came up with various suggestions of how they would manage that situation. To close the event, or one of the last sessions of the event, we were able to collect information from 17 facilities throughout Australia and New Zealand that are involved in halo management. So that's whether they are the primary hospital doing the fitting, or in some cases the orthotic practice that may be doing the subsequent ongoing care. And through that, we were able to collate the information, we presented the results, and there's some ongoing work to create best practice guidelines. So it certainly elicited a lot of engagement and conversation. We weren't able to come to a conclusive set of protocols on the day, but there is ongoing work where we can try and provide a standardised approach there based on the learnings from those facilities that are doing a large volume of halos throughout the year to assist everyone to get the best outcome for their patients. So all in all, I think it can be said that it was a resounding success, and the feedback from all those involved was that it was a great opportunity to learn and share knowledge, which was the primary aim. So, as I mentioned on day one, first cab off the rank was Mr. Greg Etherington. So Greg Etherington completed his orthopaedic training in 1999 in Sydney before undertaking spine fellowships in London between 2000 and 2002. Greg continued to work in London from 2002 through until 2007 as a spine surgery consultant before moving to the spine service in Sydney in 2007. In 2011, Greg was appointed as spine surgery consultant at the Alfred Hospital and Epworth Hospital in Melbourne, where he continues to work. So Greg gave us a very informative and entertaining presentation into the management of fractures of the spine and provided some insight into the thought process behind their management. I think once you've seen Greg's presentation, you'll agree it's a great reminder that surgeons we deal with on a daily basis are human, and they value open and honest communication regarding the most appropriate orthotic management, and they want our knowledge as experts in the field of orthotic management on what is the most appropriate orthosis for that patient. And it's important to take into consideration not only the injury, but the patient, their capabilities, limitations, and psychosocial situation. So I think throughout Greg's presentation, I think it reinforces the importance of establishing and building really good relationships with our referrers to ensure the best outcome for our patients. So I'm now going to hand over to the recording of Greg's Spinal Interest Group 18 presentation. At the end of Greg's presentation, he is going to call in, and there will be the opportunity for you to ask some questions should there be questions that arise throughout the presentation. So enjoy Greg's presentation and hold on the line to the end so you can ask some questions. So thank you very much.
Right, my name's Greg Etherington. I'm a spine surgeon around the place. So I was asked to give a talk to a whole bunch of orthoses. Now, 100 years ago when I started this nonsense, the orthoses sounded like a rock band, quite frankly. And it went quite well with orthopaedics, so I thought, oh yeah, that's good. So I was supposed to talk about how surgeons think. Can you share how everyone else thinks? Oh yeah, not a problem. I'll tell you about teenagers as well while I'm there. So, fairly broad topic, but I sort of chose a few things. So first of all, I can talk about what I know about it, but I cannot talk for all my colleagues, and I certainly can't talk for all my neurosurgical colleagues. That's a different freaking planet, quite frankly. So, from my own background, 100 years ago, I did some orthopaedic training. When I went over to London to do fellowship, so there was a big chunk of neurosurgery in there. And although I'm associated with orthopaedics around Alfred, in fact, I far more with many of my neurosurgical colleagues, but not all of my neurosurgical colleagues. Oops, wrong one. Okay. So, you do your this is how you learn about orthotics. You do your orthopaedic training, and in your orthopaedic training, you do run across non-operative care, okay? And non-operative care consists of saying, there, you'll be fine, right through to actually, we need to do something about this. And plasters and orthotics are brushed over. I've got to say, in 4 years of orthopaedics, you probably get about a total of half hour teaching about orthotics, okay? I would say skimmed over, just as a mention of this doesn't need an operation, you probably need a brace. There is certainly no gory details. There is a few trainees that get a bit more interested and by their own volition go out and find out a bit more. Now, so in the world of orthopaedics, most people by the end of their training decide they need more training. And so they go off and do a subspecialty of some description. So this is sort of the next tier. And that subspecialty is a variety of things. It could be spine, it could be upper limb stuff, it could be trauma, it could be shoulder, elbow, foot and ankle, blah, blah, blah. Now, obviously, with each of those subspecialties comes their own sub-interests. So I get to find out a bit more about halos, about collars, about thoracolumbar braces, blah, blah, blah. The upper limb guys get to know a lot more about hand splints, probably from the hand therapist. There's a bit of overlap with you guys. Trauma, pelvic fractures, knees, sports physicians, all this sort of stuff. So in each of the subspecialties, they learn about their own subspecialty bits, and that includes some non-operative care. And then, even if you take one of those subspecialties, it depends on what you want to do within that subspecialty. So I've got a fairly broad interest in what I do, and that's fine. But there are some guys who are out there say, no, I'm just going to do lumbar stuff. Thanks very much. I'm interested in lumbar surgery and total hip replacements. I'm out of here. And so, okay, that's fair enough. Alfred do a lot of trauma. Don't do any paediatric deformity. If you work in the world of paediatrics, that's a whole group of bracing and non-operative care associated with them. So you can see how you gather bits and pieces, being more specific as you need them. Okay, but I've got to say, it's not thorough, it's not complete, and so there's a lot of variation in any surgeon's own experience. And there are some people, like Sulu, my boss over at Alfred, who seems pathologically devoted and knows far more than I will ever care to know about bracing, or she's far more black and white. Whereas myself and most of my colleagues say, well, look, I really don't know about this, that's why you're here. So, my training, again, initial orthopaedic stuff, then you get to know about spine, but my training in orthotics can be brought on a post-it note, really. And so, we love orthotists. That was very cool, I found it in my case. Okay, so, bottom line, I know bugger all about the secrets and the black arts of orthotics, okay? Don't let them con you. But I do know about this shit. Sorry, bleep that one out. This is for videos, folks. I do know about this stuff. So, what I wanted to do is, again, teach you how I think, and probably what several other surgeons, but not uniformly, think. So, if we're talking about thoracolumbar trauma, because there's another talk on cervical trauma later, there's non-operative treatment, and there's plenty of controversies. What are the controversial stuff? Well, there's just a few. Classification, stability, prognosis, natural history, non-operative care versus operative care, what are you going to do about it and what are you going to do about it? But apart from that, it's all rocket science, it's all solid science, okay? So the treatment aims, however, whatever you do, are all the same, and that's fine. You want to prevent someone getting worse. Yeah, that's a good idea. You want to prevent them bending forward. Yep, that's a good idea too. You want their fractures to heal. Fair enough. You don't want to balls it up. You don't want to have a complication. And you want, at the end of the day, a year or two down the line, you want a good result. So that's fine. It's just a matter of how you get there that's the controversial part. What do we know about them? Well, lots of them occur around T12 and T11. And many of them occur at other levels as well. It depends on how hard you look for them. There's rocket science. If you look harder, you find stuff. Most vertebral injuries don't need me. Okay, they might need you, but they don't need me. But there's a lot of variation in the definition, and that makes it very hard to pick apart. All treatments, including yours, have complications. It's just that your treatment can't give such a bad result as mine, okay? So bad surgery gives worse results than not doing surgery at all. There are some randomised trials out there, definitely, and every time they're presented, they are torn to shreds saying, oh, I never do that, or no, that's not right. And you think, oh, dear God, these poor people have struggled to get a randomised trial going and everyone's shredding them. There are lots of studies on, oh, we use this and it works, and we use that and it didn't work, but it works better than your bit does, and you think, right, okay, yeah. And there are several really crazy people out there, and, well, they're in everywhere. Righto. So what do we also know? Well, paraplegia is generally bad for people. We agree with that. Neural deficit and pressure on nerves, most of them will get an operation, okay? Not all. Arguably, they don't need it, but most will get it. There's other factors too about CSF flow around the spine, which are also an important consideration, especially for longer term. Significant bony deformity does not always cause problems, and we'll come back to that sort of word later. But overall sagittal balance in a patient is important. Not all unstable fractures get an operation, and some stable fractures definitely do get an operation. So, and if you've ever heard this, they're lying, or they clearly have no idea what the real world is like, because everything is a problem. So, one of the topics that recurrently comes up, like a thorn, is stability. And the trouble is, it's not an on-off switch. It's a grayscale. So, at this end of the scale, you've got a guy who's got a fractured transverse process. You say, yep, no worries, Panadol, have some concrete, toughen off, now off you go. And that's fine. At the other end of the scale, you've got this guy who tried to tear his head off and got some other injury, and he's now an organ donor, okay? Everyone would agree that's an unstable injury. In fact, the treatment was exactly the same. I didn't go anywhere near him because this one's too bad and that one's too good. Now, of course, that's there, and this one's here, and there's a lot in between. So there's a lot of grayscale in the middle here, and therefore there's a lot of, is that more unstable than that? And, it's like the difference between 50 and, when, 51% of people get better. What, so 49% of people don't. So that's a fracture. Is it unstable? Well, depends what you want to do. If you want to go horse riding, yeah, it's probably not very good for you. What about this one? This is an odontoid fracture. 37-year-old guy, neurologically fine. But I'd probably operate on that. More because I'm worried about non-union, not for now. I'm not worried about his head falling off today, but I am worried about it not uniting and what I have to do to salvage the situation if in 9 months' time he is still symptomatic. So some fractures you operate because today they're unstable, today there's a problem, there's a neurological deficit, there's a significant deformity. That's today's problem. Also, there's a group at the other end where I think, like him, young guy, good bone, odontoid fracture, great position, I want to keep it there. This is one of the best operations I do. I just put a screw up there and I'm actually restoring anatomy. It's one of the rare times in spine surgery we're not actually fusing multiple bones together. So I think this is a great operation, but it's more to prevent a longer term problem, not today's issues. And there's a group in the middle here where I think, yeah, I think that'll probably be okay. Probably. And I'll put you in a brace, the magic brace, and if you wear it, and if I follow closely enough, and if things go okay, then you'll be okay. So I will be okay, doc. No, I didn't say that. I said you'll probably be okay. Well, how probably is probably? Is probably like 90% chance of okay and 10% chance of not okay, or is it 50-50? I said, no, it's probably more than less. Thanks, doc. Good advice. Well done. You went to uni for that, did you? So you play the odds, and you think, yep, this guy will probably be able to treat non-operatively. Okay, so again, going back to what could possibly go wrong. So you've got to start somewhere. Classifications of thoracolumbar injury has been going for quite a while. Remember when things were invented, X-rays through here, CT's about there, MRI's about there, and that has a definite relationship to the classification used. So these ones from here up, they were predominantly talking about the vertebral body, the bones. There was a bit of recognition about bony injuries, but not so much about soft tissue stuff. Whereas when you start inventing MRIs, you see ligaments and you see the discs and you see the spinal cord. And so the classification systems now are sort of including a bit more in the soft tissues. So it's no good just to look at an X-ray or a CT. So this is the classification system, which is common enough. And this is not an exam, you don't have to memorise all this. But the take-home message is, okay, over here, if you start with a significant vertical displacement or a dislocation, so something's twisted around, you think, that's bad, that probably needs an operation, right? If you don't have that, you might have a tension band injury, so that the posterior elements, you know what I mean by tension band? Okay, so see that crane outside? Where is it? That crane is standing upright. Interestingly, I don't know how, but it's doing it. So on this side of this crane here, have we watched, actually that yellow crane there, see how that yellow crane's putting concrete on the top there, okay? On the inside of the arm, there's this huge amount of compression trying to hold it down. There's something holding it upright here, okay? So that's the tension band, the side under tension. Now, if we just do a little bit of a nick on that steel there, the whole thing would cave in, which would be interesting. So if your tension band's disrupted, you tend to distract that way. So you throw a bit of tension band disruption and you've got another set of injuries. If the vertebral body is fractured, and then you get the really feeble fractures like the transverse processes and stuff like that. So you think, yeah, I can work with that sort of classification. I can't remember all the details and what number is associated with what injury, but the principles I can sort of understand. So you think, okay, now I'll know what to do. I'll know what to do here because I've got a classification. So you look up here and you think, okay, what's the fracture mechanism? And it's a compression fracture and that gets a 1. And if it's a burst fracture, it gets another 1. And this gets a 3 and that gets a 4. And you think, okay, right. And I add that score to this score, which is the neural, and I add these scores to that score, which is about posterior elements. And then I get a score. And if you've got a score, you're well down the line. You get a score of 3, you don't need an operation. You get a score of 5, you do need an operation. How easy is that? And if you get a score of 4, which of course is the most common score, you can do whatever you damn well please. You think, I hope they spent a lot of money on that one, like those consultants you hire in to tell you what you already know. So this, this is not a lie, okay? The most common score when you sit down is 4. And you think, And even if it said operative care or non-operative care, it doesn't say which non-operative care or which operative care. You think, okay, well, we're sort of partly there. So, just a bit of classification. Now, because this classification relies on information, you need at least an X-ray, at least a CT, and probably an MRI. Now, that's sort of standard. So, if you've got a little old lady with an odontoid fracture who probably get an X-ray and a CT, then that's all she'll get, because I'm not really interested in about soft tissues. But other people get MRIs as well, and the trauma team like MRIs, and I think everyone should be magnetised. Where I work, most people get multiple of everything. Okay, they get multiple MRIs, multiple CTs, multiple X-rays, usually multiple opinions from different registrars, but that's another problem. And then it's always, oh, we'll just have to wait for Dr. Etherington to come by. Yeah, okay, that's good, thanks. Now, so surgical indications. So this is probably one of the least arguable indications. So if someone comes in and their neurological status is getting worse in front of your eyes, that person will get an operation, okay? Their compression will get decompressed, their alignment will get realigned, metalware will get put in, da-da-da. And that's not really controversial. More controversial if they arrive in the department with a significant neurological deficit which doesn't change. You think, well, that sort of needs a decompression. But there's other factors, because that guy way back at the beginning on the black end of the scale, you know, he was quadriplegic, and that he definitely didn't get an operation for other reasons. Rotational component of the deformity. So again, if you've got a rotation, more unstable sort of injury, that takes a lot of force to do that to a spine. They're, again, more likely to get an operation, even if they're neurologically intact, although they probably add up to 4 on that scale. So injuries that go through the disc and through the joints and out through the ligaments here are more likely to get an operation because of the longer term. Okay, they are less likely to unite than a fracture that goes through the bone, through the pedicle, and out through the spinous processes. So those people are more likely to get an operation, but not for today's problem, for 6 months or 9 months problem. Other things, and this is at the Alfred, we see a lot of broken up people, and so I operate on fractures that if it was an isolated injury, I probably wouldn't operate, okay? So, but if they've got a broken head, a broken arm, 2 broken femurs, a fractured pelvis and a fractured spine, it's just easier for me to operate on the spine for everyone else's benefit, okay? Because the limits of non-operative care, putting braces on people who are stuck in bed or got multiple injuries and they've got chest tubes and it's just too hard for everyone. This is really, really debatable, is whether my operation gets them up quicker and out of hospital. That's, I've been told by a variety of administrative people that me operating is quite expensive, which is true, but keeping people in hospital is also expensive. So that one is harder to really quantify. And when I was in the UK, there was a place called Oswestry and a couple of others who were just incredibly conservative with their spinal cord injuries, right? And they would argue, quite reasonably, look, this 20-year-old kid has got a spinal cord injury. You can operate as much as you want, you can stabilise his spine, but the bottom line is his recovery is dependent on his spinal cord getting revascularised and turning back into normal. If it takes 6 weeks of bed rest to do that, well, so what? You know, if your outcome is better with 6 weeks of bed rest and you're able to do more, especially if it's a cervical thing, you go, actually, I'll put up with a bed rest. You think, well, and if people, you know, if I operate on someone's neck and their blood pressure is rubbish every time they sit up, I assume that their spinal cord is screaming out saying, Christ, do not set me up, I'm just hanging in there, do not take my blood away. So it's hard to really quantify that one. For older fractures, so this is sort of the acute stuff, but this is for older fractures. If you're increasing deformity, non-unions, malunions, increasing pain is always a bit, and if you've got an increasing neurological deficit, again, they're the sort of the indications for going in operatively. Now, of course, there's loads of other stuff. Okay, age, osteoporosis, how big, where they live, general health, surgeon, really important. The surgeon, what training have they had, what experience have they had, what they've seen, what have they not seen, which fracture you're dealing with, that's the easy part. Which hospital are you in? Do they have theatres? Do they have enough X-ray? Do they have CTs, MRIs? Do they have intensive care? Do they have an orthotic department at all? If so, is the orthotic on the shelf or is it ordered in and it'll be here in a week? Also, are the patients going to come back for follow-up? If they're going to come back, how are they going to, we're in Melbourne. If the patient lives in Mildura, it's a pain in the ass to get them back for follow-up. It's easier for me to operate on them and say, look, I'll see you in 6 weeks, rather than say, yeah, just come back every week. Thanks. I was really looking forward to that. If you're going to do surgery, when are you going to do it? Is it tonight, tomorrow, next week? Front, back, both. These are player comfort levels, surgeon training levels as well, which is variable at the best of times. If it's going to be posterior, there's bits and pieces. How long are you going to do the fusion? What are you going to do post-op? Is it mobilised? Is it a brace post-op? Is it going to be red rest post-op? As I said, a lot of variation amongst all this. So, especially with this one here, these are really two important ones, okay? And myself and my boss over at the Alfred will have an ongoing discussion about 70-year-old and 80-year-old people with odontoid fractures and how I think that should be a crime against humanity to put them in a halo, but she quite likes them. So we'll have an ongoing discussion and that will remain an ongoing discussion forever. Neither of us expect our fractures to unite. Probably neither of us will actually operate on them, even if they did come back. So you think, okay. I didn't put over here patient's address. Okay, that's also an important one. Access to follow-up. Who are they at home with? Is there someone to help them with care? Non-operative care. Well, you start little and you just, like that transverse process fracture, no restrictions, carry on, toughen up, you'll be right. We'll go to the next one. I'm going to give you some advice. Don't play football next week, okay? Just bad. Don't do that. But next year, that's okay. External splints. Yep. Plasters, orthoses. See, I didn't say what type. That's your job. I just say, this is what I want, carry on. Anyway, you can treat them in bed rest. Are you going to put in traction? Oh, do we have to put someone in traction? The nurses go, we haven't done that for since, Sir George Bedbrook was freaking alive. Do we have to do it again? Because everyone's forgotten, we don't even know where the traction equipment is. We have no idea. It's somewhere. It could be in maintenance department under miscellaneous for all we know. We have no idea where it is. Put them in a brace and keep them in bed anyway. Put them in a hyperextension brace or plaster bed. Seen that. You can get aggressive bed rest. You do have to follow up, and this is what really kills your results. You put on the best brace in the world and you think, woohoo, and then you never see the patient again, or even worse, they come back 3 months later with this perfect brace, absolutely perfect, spotless. And they say, did you want this back? Because, well, it's not really that useful for me. Some challenges with non-operative care, there's plenty. Again, what do you actually, when I say non-operative care, what the hell am I talking about? And there are complications and problems, okay? Bed rest has pressure sores, pneumonia. You guys know all the problems with the braces. Follow-up, how often do you need to see them? Every week? If they're in hospital, is it every day? Is it every second day? What is acceptable treatment? The acceptable treatment for the 37-year-old is different from the 90-year-old. How long is it going to go for? Is it, it's orthopaedics, so that means everything heals in either 3 weeks, 6 weeks, 3 months, or 6 months, because that's when we do the clinics. So how long is this follow-up for? Do we go till they're united? Do we go till they're angulated? Do we go till they're pain-free? And the longer you follow up, the worse your results. What the hell's plan B? If this all turns to yogurt in 2 months or 2 weeks, what are you going to do about it? And how long do you wait for it to go bad? Or if you're waiting for neurological recovery, how long do you wait for it to come back? Because you might be waiting a long, long time. What is acceptable pathology? So this could be neurological pathology, this could be fracture collapse, this could be pain. What's the break point? What is it that's going to say, yep, now you need an operation, okay? You didn't before, when I saw you, you didn't need it, but now you do. And what is the salvage plan? Okay, what sort of surgery is going to happen? Is the salvage worse than operating earlier? So that odontoid fracture, way back, for me to put a C1 screw in is an operation, it has risks, blah, blah, blah. However, if I get a good result, I have an anatomical restoration and nearly a normal neck. If it doesn't unite and they have symptoms, then I have to do a C1-2 fusion. They lose 50% of rotation straight up, and that's permanent. And they don't like it. And obviously it's a fusion, the next level has to take up a little more load. So the salvage is potentially a bad thing. So maybe an operation sooner to try and avoid later problems is a good idea. Now, this is all about managing expectations as well. From all of these people, I didn't put family in, but you can put family in up there somewhere. Because, you know, you guys, you give them a brace and you say, yep, carry on, manage well. And I live with no one, or I live with my cerebral palsy daughter, or some freaking family catastrophe. It's better when they're homeless, at least you can go, yep, out the door, you're home. So you're trying to manage all these different expectations here, and you think, oh, this is just too hard. I think I'll just operate, and the rest of you can get. Anyway, so the good old days, and those of us who are old enough remember this sort of punishment we used to do to people because it was good fun. And I do remember as a resident helping put these on, and I'm thinking, oh, this is just so bad. However, that's what we had, so that's what we did, so there you go. Yep. So then it sort of goes, as advertised, this is what the brochures will show. You think, wow, that's really good, I like those. In real life, you know, I get to work with hot young chicks all day. How cool is this job? Well, there's a couple of other things you've got to do as well. That's more typical. And this lady has got an old fracture, and it's just, yeah, sure, you can brace it if you want to punish someone, yourself included, but I just don't think it's a good idea. Yes, well, such is my life. No matter what you can do, it can all turn to crap. I think that's a fair thing. And those little periods where you're happy soon deteriorate. They go away. They don't inconvenience you for too long. It's fair to say you can do the right operation the wrong way, you'll get a bad result. Really, that's really high-tech, doc. You can do the right operation the right way and still get a bad result with absolutely no neurological recovery at all. You think, and you can do sort of the right operation, but not quite right, maybe a little bit much. This person has a chance injury, that's a spinous process there, and you can sort of see a line running that way. From my point of view, this is such a cool thing to operate on, because we can restore anatomy, put in some metal there and take it out, and the patient will be fine. Spine's fine. You see there's a little bit of this whiter stuff here, so that's where the ligaments have been torn a bit. And the surgeon just went crazy. That's too much metal. You do not need that much metal, and the morbidity of that operation is now starting to get a bit outrageous. She would have been better off being in bed rest, right? Keep her in 6 weeks. You could avoid all that, avoid the potential infection, avoid damage to the joints above and below. You think, you know, just And you get other ones where you think, actually, well, there's the patient before, there's the patient after, and you think, what the hell did we do there? Well, it's got some metal. Why? And then you get others where you think, oh, I don't know, this is going to be, oh, Jesus, this looks bad. Oh, that looks worse. Well, the patient comes in and says, yep, fine, thanks, doc, well done. You think, yeah, I knew that all along, really. I knew this was going to be good. So asking a surgeon a question, yeah, well, that's pretty well it, isn't it, really? So I was asked specifically about how do you ask your surgeon a question? Well, surgeons are a bit variable like yourselves. So you sort of got to work with them, not too closely, you don't want, but just enough. So it's difficult. You have to assume, talking to us, that you are the expert in the orthosis. I might just have better bluff and perhaps a bit older or whatever. But you, I expect you to know what the hell you're talking about. So when I've got a fracture and I want to treat it non-operatively, I'll usually say, this is the fracture, this is what I'd like to do, I'd like to extend it, or no, it just needs a bit of support, I want to avoid flexion or whatever. I will then hand it back to you guys to come up with a solution for the problem, okay? As I'm getting older, I'm knowing less about far more, okay? When the patient says, what drugs do I take for the pain? I go, I have no idea. Some of them are illegal. They were legal 2 weeks ago, but they ain't no more. So bad luck on that one. Go see your GP. I'm sure there's something new coming out on the market. There's some illegal shit downstairs out the front of the hospital if you really want. It's all good. Just go do whatever you think's a fair thing, because I know nothing about drugs and I don't want to, okay? Not that I'm don't know nothing absolutely about orthotics, but I certainly don't know enough. And I don't have the motivation enough to do the follow-up of, weekly visits or whatever to adjust braces and to talk to the family. I'm just not that nice, quite frankly. The families just deserve punching. And if you have to do paediatrics, you really feel like the nursing staff should be armed just to get rid of a few. Anyway, so I just don't have that degree of patience. That's why you're there. Make my job easier. One of the great motivations for me to learn about braces, especially halos, was when I was in the UK where there was no orthotics department. And we didn't have a huge trauma. We had a few every now and then, but every time I wanted to put an odontoid fracture in a halo, I had to ring the company. And then the company would say, yeah, we'll order it in, and that's fine. So a week or so later it'd come in, or a few days at least. If it was a weekend, it was a week. And then I'd have to put it on, then I'd have to look after it, and I'd have to adjust it. And I thought, I think there's a limited indication for halo in my hands. Whereas where I am now, I can say, guys, can we have a halo? And they go, yeah, that's okay. Do you want it this afternoon or tomorrow? And I go, tomorrow's fine. And they go, okay, that's cool. And they say, and we follow up. Yeah, you go, carry on, follow up, tighten those pins and keep a look after and keep me posted, will you? Send me a postcard, well done. And I'll see them in 6 weeks. So availability, if you don't have surgery, you won't use it. If you don't have an orthotic department, you won't use it. So you just got to sort of find your way around. Now, what time are we up to?
22.
Okay. Now, what else? I was just specifically... Actually, have you got any questions right at the moment? There was...
One of the things we were thinking about with this, how to approach a surgeon, and it might be, I think sometimes we get inconsistent answers from registrars.
Surely not.
Just repeating what the boss says.
Oh, yeah, well, that's the idea. That's called bullying. Oh, sorry, bullying doesn't happen anymore. That's called training. I forgot.
So I guess from a practical point of view,
Yep.
we're saying this is the patient, and I guess what do you want? Although if you're not in the hospital, you're doing a list, and they put you on loudspeaker.
Yep.
How succinct you want to be? This is the patient. These are the injuries.
Yep.
You've asked for this. What other information do you want?
Okay. Certainly from, well, I can't imagine registrars giving inconsistent answers, but let alone surgeons. So there's a spectrum, shall we say. For those who don't know, registrars are trainees. They pass through hospitals, usually in a 6-month rotation. They may or may not have had experience in whatever they're doing today. The registrars change in Victoria. They change early February and in July. So at this time of year, which is only 1 month into the new rotation, they're just getting to feel what the hospital, how the hospital works, what their bosses think like, and they don't, and often if it's a big hospital, like the registrar I was on with last night, I've never met before, right? She's only been there a month, what the hell? Anyway, so that's why you get inconsistent answers, and that's also, and they bring with them their experience from another hospital, which is sometimes good and sometimes bad, or just different. Not necessarily bad, just different. So certainly at this time of year, they're more likely to say, I don't know that, I'll check with the boss, which is fair enough. By about June, they're starting to think, oh yeah, I know what he'll want this or that, okay? Or he doesn't care, just do what's reasonable. So there's that spectrum as well. What I really want to know when I say, can you put this guy in a brace is, one, is it physically possible, okay? That CT scan of this really obese lady, I'll be looking at that thinking, yeah, I just want to punish you guys. Yeah, I'll have a brace. Go on, there. And I would like some feedback to say, Greg, you wanted a brace, you've got to be freaking kidding. He's got chest tubes coming out here, he's got this, he's got that. We can't do that, don't be bloody ridiculous. Or actually the halo is not going to work, there's a big laceration here, or they've got scalp things, or they've got a skull fracture, didn't you know about that? Oh yeah, sorry. Or it's a bit of a negotiation. Yeah, we've got a skull fracture and we've got something that needs a halo. Let's have a really good look at the CT. Maybe we can put the pins just in the right place so we don't actually put them intracerebral. So it's often a bit of, so when you guys ask me what do I want, it's partly to say, I have no idea what you're talking about. That's fair enough. I usually go, well, I don't know what I'm talking about either, but I know what the injury is. So I'd like your assistance to tell me what you think, because you're the freaking experts, that's what it says on the badges, about what brace you think is reasonable for you to apply and has acceptable complications and reasonable follow-up that this can give a good result. I don't expect perfection. I don't expect, unlike the patients, I don't expect necessarily the first brace, especially in some things, to be the one that they wear for the full 3 months. That's just silly, okay? They do need, it's gardening. You need to go out, adjust this, change that, reassure, change that, or at some stage along the line, come back to me and say, this is not working, or the patient's just not wearing it, okay? So I do expect you to be able to manufacture or procure the brace somehow, to apply it appropriately, to give reasonable advice to the patient, the relatives, or whoever's going to be looking after it. And certainly where I work, I can get you to look after it. A lot of the brace questions, okay? I do not want to be bothered. I've got enough freaking registrars asking me questions. I don't want you asking me questions like, oh, there's a pressure sore under here. I don't care. Fix it. Tell me, by all means tell me. And if they keep on getting pressure sores, then maybe I have to change plans. Maybe I have to say, right, the brace is not working. That's a break point. We either bin the brace entirely, we're not going to use it, and we're not going to do an operation. We're going to take our chances. Or we're going to say, oh, if we can just keep it going another couple of weeks, and that'll be fine, that'll be good. Or we say, no, definitely not working, the fracture's displacing, patient's getting more pain or a neurological deficit, this is the time to change from non-operative care to an operation, okay? So, you know, like everything in medicine, it's all about communication and that sort of stuff, and I absolutely appreciate there are some surgeons out there who are absolute arseholes and you don't want to talk to, you certainly don't want to invite home, and they'll say, I want this brace, like they're going to be looking after it. Oh yeah, okay, here's your brace, now piss off. damn it. But they're just people, okay? They don't know as much as you know about the braces, definitely. And they certainly don't know the cost of the brace, have no idea about the cost of the brace, or how much time or effort you will be putting in to look after this brace and the patient and the family. So you can't assume that they really know too much at all. They've got an idea, that's fine. They might have an idea of the procurement process of costs to the hospital of a brace or that sort of stuff, but generally they're not going to know enough detail of the complications of the braces that they're, prescribing is probably too strong a word, actually. Suggesting is probably a better one. I mean, Sue's very adamant about her thing. It's fine. But I like to give people the flexibility for you to change things if you think it is reasonable to change it, or if it's not working, tell me about it, or at least flag it up. We'll talk about it and we'll make a plan. Does that make sense? But, you know, it depends on where you are, which hospital, which surgeon, what day, you know, have they had an argument with their wife that morning or whatever. So, what else did I want to talk about? Oh, yeah. Chance fractures. This is a classification thing. Mr. Chance, it's a Mr. Chance, it wasn't a fracture by chance. Mr. Chance was a radiologist, Reginald Quinton, who described an injury in 1948, so this is well before CTs, and he described it in motor vehicles, which were around, number one. Number two, not all of them had seat belts. Number three, if they did have a seat belt, it was probably just across the sash, across the lap, not around there. So he noticed a number of injuries which involved around the thoracolumbar junction where it was opened up at the back. And get a bit closer here. So it was distracted at the back and not so compressed at the front, although later. So that's what he described was that injury. That has now broadened out a little bit and includes some with little fractures of the vertebral body and other ones that go straight through the disc, up through there, through the facet joints and out there. So it's completely soft tissue. So that's sort of the same mechanism of injury. They all involve, usually they involve, strangely still car accidents, where the top of the patient goes that way and the bottom of the patient goes that way, and across the middle there is something that restrains them, okay? So with chance fractures, I mean, I quite enjoy them because they're really easy to fix or easy to treat non-operatively. This is one. You can see all and the clues can be quite subtle. You think that distance is bigger than it should be. And you think, is that real or is it just me trying to talk myself into it? And you think, well, yeah, it's suspicious and maybe that's a little bit there. And then you look at about cider and you look at the facet joints and they're a little bit wider. But of course, this is the patient lying down in a CT sometime after the accident. The other thing is you've got this swelling here. You think, that's not normal either. So that's a significant posterior swelling due to bleeding. And the other thing is this line of clips here. So with this injury, because of the mechanism, you can imagine a seatbelt here, the patient gets flung forward and the seatbelt goes that way, okay, and squashes everything in between here and the spine. So there's about a 60% incidence of having intra-abdominal injury of some kind, mesenteric tears, liver ruptures, blah, blah, blah. So they frequently come in and need a laparotomy to save their life, and then the spine injury is found a few days later. Okay, that's pretty common. Treatment for the spine injury, frequently they need operations. And all you have to do is you go in the back, put some screws and just clamp it together. Good fun little operation. Or if you're totally otherwise uninjured and you've got, especially if your fracture is through the bone, you can treat them in bed rest on a bit of hyperextension and that'll be fine. hyperextension brace, as long as they wear it, that's good. So there's a number of different possible options for that one. What else have I got there? No, that's about it, I think.